Hi everyone, how are you doing? I'm going to share the didactic for this week's lecture. And forgive me, I'm recording in my dining room and I realize that the sound quality is not great because it's all wood in here. So I'm not absorbing any of the volume. And I'm looking around and I don't think I have anything to really mitigate it. So I'm going to do the best that I can. Anyways, um, so we're going to talk about, obviously we'll do the group presentation in class. And then we have a vignette activity that we'll do in class as well. These are the diagnoses that you've read in the chapter from the DSM and in the CREST textbook. They're, I think, a little bit out of order on this slide as it relates to the actual order in the didactic. So forgive me for that oversight. We'll do a warm-up quiz in class. So just know for your sake of learning, what I really want you to do in preparation for the final is just have a basic understanding of reactive attachment disorder and disinhibited social engagement disorder. I just want you to know that really the combination, what the DSM talks about is the combination or the connection between reaction attachment disorder and disinhibited social engagement disorder is that there is an absence of adequate caregiving that a child goes through. We know that attachment issues start to form within the first 6 months of life. In order to actually meet criteria for this, development of these disorders, of these behaviors, must be shown after 9 months and by the age of 5. So between 9 months and 5 years old, we're going to see either one of these symptoms in order to meet criteria for either one of these disorders. So within reactive attachment disorder, this is what we would identify as an internalizing disorder. So as a result of a lot of neglect, of abuse, of really either disorganized, absent, and usually it's, I would say, disorganized attachment really has the most damaging impact on an individual. We see that in childhood and we see that with regard to adulthood for sure, where a child does not know how to be able to feel safe with a parent. Like that's the easiest way to think about this, is that the disorganized attachment really is, do you love me or not? Am I safe or am I not? So if we can only imagine just, I don't know if you've ever worked with anybody that's like this. Unfortunately, in doing this work as a therapist, we will come across individuals, perhaps not even meeting criteria for this disorder, but just that have had disorganized caregiving, and it's terrible because with this plant, again, this plants a seed that children are not to know how to be able to find comfort and solace and consistency in their caregivers. So with reactive attachment disorder, this is where we're going to see internalized behaviors such as inhibited, emotionally withdrawn behaviors, pardon me, where whether it's in those caregivers or subsequent caregivers, then the child is not seeking comfort, they're not responding to efforts to be comforted, and we see this additional demonstration of a limited social engagement, social responsiveness to others, limited positive affect, difficulties with regard to managing irritability, their fear, sadness, even in the absence of an actual threat. And so we just see when there are extreme issues of attachment, how that continues to, I mean, these disorders cross the wires for a child. And so how much that actually does make an effect throughout the child's life and moving forward into the rest of their lives. So I had a teenager that had reactive attachment disorder, and the situation was that she was a 14-year-old girl. When I started working with her, she came in, she was referred by her school. She had extreme socialization issues. She didn't have any friends. She was really kind of just odd. She had very limited emotional expression when I started working with her. And her background was that her mother, her biological mother, was very young when she had her and was addicted to meth. This is when I was working in East County, and this was such a frequent issue that we'd see within caregivers in general, just meth use in general, in that particular region of San Diego. And so she was removed from her mother's care when she was like 10 months old, and because of just how neglected she was. And she was placed with mom's older sister, who was, she tried, but the woman was just a biatch. Like she was just so cold and reactive as like the wicked stepmother type of a situation. And she just would just criticize my client for everything. And so, what the DSM talks about is like with reactive attachment disorder, children unfortunately experience the negative effects of trauma and of attachments within their caregivers, but not all children actually come to have reactive attachment disorder. And it really just depends on the continued environment and conditions of their upbringing. And so this is where it really did, I could see how if she was in a warmer environment growing up, it's very possible that her temperament would have been a little bit different, but she just, oh gosh, I just felt so terrible for her. She'd have these like really overwhelming tantrums that where she would like implode basically. So she would just start to almost like spectrum disorder where she would start engaging in stereotyped behaviors, like hitting her head on a wall, or like she'd like scratch her hair and like just start, what's the clinical word I'm looking for here? She would just start to like shake incessantly. That's not the word. And it was like she was in a trance, and she just could not actually regulate herself. So it was a big challenge because then her her adoptive mother, her aunt, would try to calm her down, but she would get frustrated. And so it just would be this vicious cycle. But that's where I could not figure out what the disorder was for her. And then I found reactive attachment disorder, and I was like, this is it. So it was tough working with her just because of her family system. She was she could warm up in session, but you could just tell that she really did not have much capability of connecting in an attachment, of attaching. She just was very, very withdrawn. So I'm going to compare that to another client that I had that had disinhibited social engagement disorder, who I remember this was at a different elementary school that I was working at, where I was providing social skills and independent or individual and group social skills to elementary school students. And the school counselor, oh gosh, that was like a whole other case study in itself. She actually lives in my neighborhood and she's just awful. I saw her recently after I hadn't seen her in like 20 years, and I knew exactly who she was. I never forgot her because I just remember how terrible she was when talking about the kids. For me, it was like, I will never, ever, ever. It was such a helpful, it was my first year of grad school, and sorry, I'm being circumstantial and telling the story, but separately for me, it reinforced, I will never be this kind of clinician. Like I will never get to a point where I'm burnt out, where I'm talking about my clients in this way, because she just was awful. So I remember I had this, he was a 10-year-old student. He was having difficulties with his acting out behavior, and she described him, part of my friend, she described him as a little shit. And she kept saying that word. Oh, he's just a little shit. He just is such a terrible kid. And I was like, what? Oh my gosh, like what kind of kid am I going to be working with? I remember he was just the sweetest kid ever. He was like a little puppy dog. And he had awful traumatic history. Same thing, had been neglected. I mean, I think he had been left like, I'm not even going to tell these stories because for some of you, this is just too horrific. But just trust me, he had been severely neglected and abused. And I thought he was the sweetest kid. What was interesting, if I can say, this was like my third meeting with him, we were coloring. And you could just tell that all he wanted was love. That just like he just wanted love and connection. And we were coloring, and he looked at me and he said, "Lindsay, I love you." Oh, my heart melted. And then I started to get concerned clinically because I was like, oh my gosh, this is not appropriate. Like, is sweet, and I just wanted to attach to him so badly. I was like, this is really not appropriate behavior. Me just having worked with him for such a short period of time, attaching very quickly. And so that behavior coming and just a reduced reticence and approach. I think he hugged me when I first met him too. Um, and again, I could say that all he just wanted was love, but I was also concerned about what kind of situations is this kid in if he does not have stranger danger. And that's what we want to see in kids. We want to see a reticence in approaching strangers. We don't want to see an inability to warm up even after safety and security in relationships, which we would see in reactive attachment disorder, but we don't want to see disinhibited behavior. This example that I use is taken from, I forget what the name of the book is, The Boy Who Was Called It, I think. I have to look this up and come back to it. But this psychiatrist was working with kids in Chicago and had assessed a 7-year-old girl. And shortly into their initial assessment, the girl walks into across the room, climbs onto his lap, and then snuggles in his arms. And then I think had even started to initiate that she was going to stroke his genitals through his pants. Um, so this was obviously incredibly concerning. He, no surprise to him, found out that she had been severely sexually abused. And so just both of these disorders where we see the wires are crossed, where they're either blocked or just completely let out, where kids either learn that they can never be safe or that they have to attach to everybody because of what they've experienced, not consciously, subconsciously, of course. But again, that's where I think about the wires have crossed, where there's a disconnect of love and danger. So children either find that they're always in danger, or that anybody that shows some sort of connection to them means love at the risk of danger. So this slide is not from the DSM, but I actually put this in the slide because I wanted to show just this spectrum of stress versus trauma. I actually created this for my nurses at Sharp, and just in the general, in the general education that I provide in understanding trauma-informed care. And I know that depending on who we are, what kind of clients or patients we work with, the word trauma is also used indiscriminately. And so I've just found that we want to have some sort of visual to describe a spectrum of normal stressors that we go through versus actually trauma, PTSD, complex PTSD, etc. So at the bottom of the slide, this is just normal stress, right? Like us experiencing stressors. I have had a challenging week. And I know that after I film this, I'm going to just rest today. I'm going to rest tomorrow, Sunday. I need to bounce back. I need to get rest. I need to recover. But I know that I'm capable of being able to cope with a normal amount of stress. Um, I will tell you all about another real life situation that just recently happened that speaks to people I support and how we look into their ability to manage stress or distress. But moving up on this thermometer, now if we do not have the ability to take a break, to rest and recover, to get support, to use our resources, and easily bounce back, our stress might become distress. Like if I really don't know how to take care of myself, if I don't practice what I preach, if I really don't take care of my basic needs in response to my awareness that, hey, Lindsay, you've had a really hard week, you've had a difficult period of time, it's impacting your choice of food, you're going to snacks, which, we go to the low hanging fruit of um, immediate gratification. We so often do this as humans, but if I wasn't practicing all of the tools that I have, then there might be these moments where I become very highly distressed as a result of ongoing stress that I haven't been able to resolve. Now, if we experience complex stressors, like without the actual ability to bounce back, or if we experience just like difficulties in relationships to the point of attachment injuries, we could call this traumatic, but it doesn't actually meet criteria for acute stress disorder or PTSD. This is what we would say is like stress injuries, where it's not just a matter of being able to recover, where we actually need professional support. And so in doing my work at Sharp through the stress first aid model, that's exactly what I teach about, is that when we have stress injuries, extremely stressful situations that don't actually cause symptomatic criteria for trauma, but can be close to that, then that's really stress injuries that we need some more support with. Now, when we're actually exposed to life-threatening or textbook situations that we can see symptoms that show up in the DSM that last within a month, then that's acute stress disorder. Now, if these symptoms do not cease or abate within 1 month, then anything between 3 days and, well, pardon me, oh my gosh, yeah, anything between 3 days and over 1 month would meet criteria for PTSD. So that's where I'll get into this. But if a person is exposed to continued stressors and continued traumatic events where their safety or the safety of others has been compromised, for lack of a better way to say this right now, then we could say this is really complex PTSD. I don't think that this is something that this is not something that we diagnose in the DSM, but this is where we're talking about the complexities of PTSD. And I don't actually have this slide, but I'm realizing I should put this slide up. I'll add it in class. Anyways, I always say when I talk to lay people about this that it's like, the fairy tale Princess and the Pea? Trauma leaves a mark. Oh yeah, sorry. Acute stress disorder is 3 days to 1 month, and then anything after 1 month is PTSD. But trauma leaves a mark. It's just like Princess and the Pea. So, the P is or the trauma is that P. And if we continue to experience other textbook PTSD situations, then a lot of the factors that came up for us, such as our negative cognition, different thoughts that we carry with us as a result of responding to the first trauma, those continue to reverberate. I'll speak to this more in the next slides, but I just wanted to show you just how this can actually go with regard to stress that we experience just as living life versus actually life-threatening or really, really physically, emotionally harmful situations that stay with us for a lot longer. So I think I shared this in class that the PTSD, the PTSD diagnosis is really complex. And so I tried to break it down just to be able to give you a visual. So on this attachment, I have put PTSD as two different ways of being able to look at this. What we need to see in individuals older than 6 years, younger than 6 years. Here's a checklist and an acute stress disorder checklist as well. So there are similarities and then there are some differences. So just make sure that you have reviewed these, and we'll incorporate these into an exercise in class. But within PTSD, for starters, a person has to be exposed to one or more of these situations in criterion A in order to actually meet criteria for PTSD. So whether they've experienced, well, they wouldn't, sorry, that's a bad joke. If they've died, then they don't meet criteria for PTSD because for obvious reasons. If they have witnessed somebody's death, if they have witnessed somebody else being exposed to serious injury, actual threatened sexual violence, if they've experienced that themselves, if they've learned that somebody close to them was exposed to a trauma, and I will give a real life example of this in class, that can be enough to qualify for PTSD depending on who the person is and their propensity for this type of disorder. Or it could be indirect exposure to aversive details of the trauma. Usually this is what we see in first responders and medics. While there is a desensitization that a lot of people that are first responders have just by nature of being exposed to a lot. I mean, knock on wood, I have not ever had PTSD by working in the hospital, but I don't know if this is going to creep anybody out, but I really do see people die like every single day. And I thought that I would have a much more significant reaction to it. It's really interesting what the brain and the body can do in life-threatening situations. But, you know, fortunately, my harm has never been in jeopardy. I've just seen this. So depending on who we are and what we know in PTSD, just what's interesting, just going back actually to reactive attachment disorder or disinhibited social engagement disorder. I mean, is that right? Disinhibited. Oh, you know what? I'm realizing, hold on a second. I'm realizing that you actually can't see this. Let me change this. Sorry, team. Hang on a second. Share this. Puppy, come on. My dog's here in this room with me. Pardon me for not being able to show you this on screen. Now you see this. Thunder. Come on, baby. My dog's name is Thunder, by the way. Um, thunder like lightning, like one of the rain clouds that we have on this slide. Anyways, with those two childhood disorders, there's no genetic predisposition to that. That is completely environmental. PTSD, I would have actually thought that that was the case too, because we're talking about events that could happen to anybody that could cause this, but there are different types of propensities or predispositions to PTSD. And what the DSM says on page 309 is that we can have temperamental pre-traumatic factors that could put a person at risk for essentially in their memory network. I'll talk about this toward the end of the PowerPoint. But essentially, they, depending on who they are, how a person actually experiences some sort of, how they react to pardon me, what I'm trying to say is how they react emotionally, what kind of mood or anxiousness propensities that they have, essentially their heightened arousal or heightened affective states anyways. What the text says is that those people are unfortunately more susceptible to developing PTSD as a result of having been exposed to traumatic things. So that's where we see a difference between having gone through trauma and stressors versus having symptoms like this that really meet criteria for the disorder. So I hope that makes sense. If you have any questions about that, please ask me in class and we can talk about this. But in order to meet criteria for PTSD, there has to be one type of exposure. We have to see at least one type of intrusive symptoms, one type of avoidance symptoms, two types of negative alterations in cognitions and mood, and two types of arousal and reactivity. A person can, within their demonstration of these symptoms, can demonstrate dissociative qualities that would cause us to warrant or to put a specifier of either depersonalization or derealization, that's how we see some of these symptoms come out. Or we could see that their full criteria of these symptoms doesn't actually appear till after 6 months after the trauma. And that even despite the immediate onset of some symptoms, that they're actually not meeting full criteria. So maybe they're just really avoidant and isolative and have negative thoughts about themselves, but we don't see an experience of nightmares, flashbacks, unwanted upsetting memories, which I don't know, that it can happen. So it just really, again, depends on the person. Maybe that wasn't the best experience because I do really think that the memories can happen pretty quickly, but it just depends, again, on who the person is and how they actually respond. So we just have the ability to actually specify how this is showing up. We know that, of course, PTSD causes an impairment in functioning, and this cannot be attributed to any of the rule outs that we're typically used to ruling out. And we would want to identify that this is happening over a month after exposure to the actual trauma. So if in individuals younger than 6 years, this is what is a little bit different. I'm not going to really spend a lot of time on this because I'm just not really going to teach to this, but know that this is a breakdown of this. The biggest difference between PTSD in individuals younger than 6, so children under 6, versus adults, or oh, pardon me, I'm sorry, uh, children over 6, is that we do not have the opportunity to, it's not a matter of indirect exposure to aversive details of the trauma in criterion A, and just the negative alterations in cognitions and mood are a little bit different too. So again, I'm sorry, this is just where I'm not going to spend a lot of time on this. Just know that there are differences. Here's a PTSD checklist. I'm going to bring this into class. We will use this. And here's the acute stress disorder checklist. And so the clusters are different in PTSD versus acute stress disorder. And the biggest one that I always think of is the dissociative symptom, try this again, dissociative symptoms. That is present where in PTSD, we have it broken down into specific, like 4 specific categories. And all we see with acute stress disorder is that a person just needs to demonstrate 9 of these subcategories within the month of symptomatic response. Okay, so I'm going to go back to the slide. I'm referencing here the case study in the CREST textbook, and what I've done is just underlined how she meets criteria. So she's been exposed, this poor girl, she's been exposed, she's 15 in the vignette, she's been exposed to indirect, or she's been witness to trauma through her mother's addiction and being forced into prostitution. So, you know, we also know that she has been exposed to being abused and battered in past relationships. And so what we would assume is that Imani has actually witnessed that. So that meets criteria right there. But unfortunately, she also has been sexually abused by different boyfriends. And so that alone, we know that she meets criterion A. What we see are a lot of intrusive symptoms that she's having. And we see that there are a lot of actual, wait a second, I'm gonna go back. We said that there are a lot of negative alterations in cognitions and mood that she's experiencing. So she has a lot of memories, intrusive thoughts about the abuse. And that's when it says Imani struggles with intrusive thoughts about her sexual abuse, that is actually speaking to the intrusive symptoms, the unwanted upsetting memories. The difference between unwanted upsetting memories and flashbacks are the unwanted upsetting memories. These are the intrusive replaying of these situations. So I practice EMDR outside of this work, and typically what we can point out is that when a person has experienced something traumatic, there's one particular focal point about the memory that's like the worst part of it. And that's usually what unfortunately gets replayed over and over and over again. And so that's what we hone in on as a, or home in on as a starting point for doing the EMDR. Within this vignette, what we see is that she also has nightmares. She um, gets so distressed during her nightmares that she wets the bed. Poor girl. And I know this is not a real, I don't think this is a real case vignette, but I can't imagine that this is a completely novel situation. We do see that there's some subtle hypervigilance in taking on a parental role and wanting to protect her sister from abuses that she suffered and witnessed. So I'm going to switch back to the PTSD recipe. When we talk about arousal and reactivity symptoms, this is the externalization of a reaction to trauma. So we certainly see instability and aggression. We also see risky or destructive behaviors, again, externalizing their dysregulation, externalizing their distress. Hypervigilance, this is an important one. I actually have a slide on here. Oh, you know what? That's what I'm going to do. But for the sake of this, just to further explain some of these symptoms, I'm going back to criterion B. Emotion. So I have unwanted upsetting memories, nightmares, flashbacks. Flashbacks when the person is actually in the memory. So they are dissociated, they're back right into the memory of the situation. I think like the first type of awareness that I had about PTSD was as a child was the stereotype of a war vet having flashbacks and actually like some just being reminded of some sort of stimuli and then all of a sudden, oh, that's right, because we had a PE teacher. I'm not making this up. We had a PE teacher that was really had significant PTSD, and there were times that he would be like back in Vietnam and would like hit the ground or be super jumpy, startly, would like just shout out different things. And then I remember that they didn't come back to school the next year, which is probably a very good thing. But that I remember that PTSD was known for like being in the thick of their distressing memory, like they were right back in those life-threatening situations. What we also see is in after being exposed to traumatic reminders of the situation, being exposed to um, the person that actually was the perpetrator, stimuli that's akin to this. I remember I was whitewater rafting like 10 years ago and our our raft flipped and we almost died. Um, it was the scariest thing ever. And it happened right at the beginning of our run down the Kern River. And we I had to reprocess this when I trained in EMDR actually, because it was pretty scary. But what I couldn't even after we all got out, thankfully everybody was safe. But we had to get back in the raft and we had to keep going down the river. And I just kept seeing this one repeated image over and over again of my friend going right directly towards this gigantic boulder and me thinking that they were going to die. And I could not, every time that we even hit like a little baby wave, I just started to panic. Like I just started to hyperventilate. I couldn't row. I couldn't do anything. And my friend had to like talk me down. I was an associate MFT at this point, and I knew what was happening, but it was just didn't take away from what type of reactivity my brain and my body were having. And then we actually flipped again. And I was like, there's no way I can get back. I can't even get back in this raft. Um, if anybody wants to know the story, more of it later, I'll tell you more later. But every time that I saw any sort of white cap from a little wave, I just started to get flooded. And I was crying, I was shaking. I like again, so that's emotional distress, physical reactivity. I just couldn't do it. Unfortunately, this is like total God story. If anybody wants to hear the rest of the story later, I'll tell you. fortunately, I was able to like really recover just that day, but I remember it was so scary. It was so scary. And so my body was like, nope, 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 we're not doing this. And there was no, this was like the hardest thing is there was nothing I could do because like we were going down this river. There was no outlet. Like if I wanted to stop, I'd have to like call the park services and have somebody come with a helicopter to come get us. So I just had to deal with it. But man, it was really tough. So yeah, that was awful. When I'm talking about sea avoidance symptoms, um, this is a really common symptom that anybody that has experienced trauma, they don't want to continue to be exposed to the intrusive symptoms. And so as a result, this is where people can get numb, they shut down, they stop associating themselves with people, places, or things that remind them of these symptoms that we see in criterion B. And so the avoidance, though, that really speaks to its own separate symptom because it's not a matter of just having the emotional distress, the physical reactivity, but changing behaviors in order to prevent or mitigate those symptoms coming up again. Arousal and reactivity, criterion E, or pardon me, I'm sorry, going out of order. Criterion D, negative alterations in cognitions and mood. This is where these symptoms, again, depending on who the person is, they could begin pretty quickly after exposure to the trauma, but can really linger, especially when we're talking about negative thoughts and exaggerated blame of self. And so inability to recall key features of the trauma, this goes into some sort of like localized amnesia that the brain is really trying to protect itself. Also, when I say of overly negative thoughts or assumptions about oneself or the world, or exaggerated blame of self or others, what we see are, and this is taking from a framework that we use in EMDR, is we target negative cognitions that are really the most prominent that a person takes with them. The best way that I can describe this is for some messed up reason. What happens, despite evidence to the contrary, after a person has been traumatized, is that instead of having a rational, processed understanding of it wasn't my fault, even though I wasn't safe then, I'm safe now, I can trust other people. What happens is that the brain really has this reverberating statement that is made over and over again. It was my fault. I'm not okay. I'm not lovable. I'm the one to blame. I can't trust anybody else. I should have done something. People aren't safe. That we really try to home in on that particular statement because that is the connective tissue that we use to align with the actual memory, and we want to reprocess all of that because what this is, this particular criterion set or set of criteria, pardon me, these are really the more difficult ones to treat. These are the ones that we're going to see in a different type of prominent way before we're able to actually assess and confirm all of the PTSD. And these ones linger the most, but especially those negative thoughts about oneself, exaggerated blame of self, it's my fault, I should have done this, or it being really internalized as this happened because I'm not good enough, this happened because I'm not lovable. That's what we want to really seek and treat. Depending on what kind of trauma treatment that you use, it goes about those components in a different way. This is why I really love EMDR, is because it just captures a lot of these different aspects from the diagnosis. Moreover, we see negative affect, decreased interest in activities, feeling isolated, difficulty experiencing positive affect. So that's really anhedonia, it's the last one. But we see irritability. I mean, this could look like depression. They're isolating themselves, just really not wanting to engage in a lot of activities, connections with people, and then feeling isolated. So like person is disconnected, offline. They're really just shut out of the world when they are experiencing these symptoms. And then lastly, with arousal and reactivity, depending on who a person is and what kind of trauma they've experienced, this is where we would see the externalization of these symptoms. So if we think about negative alterations in cognitions and mood being an internalization of the trauma, the latter is the externalization of the trauma. So irritability, aggression, risky or destructive behavior, hypervigilance, which again I'm going to talk about, a heightened startle response, so being really jumpy, difficulty concentrating, difficulty sleeping. So this is where it's a lot of that trauma coming out in a person's behavior, in their life, in just how they're actually experiencing different aspects of this trauma, which with the idea of trying to protect themselves. Okay, so now I'm back to this case study. I hope I wasn't too circumstantial and like too tangential with all of this, and that I could keep you connected to what I was talking about. Anyways, back to the slides. So Amani, what took me down this rabbit hole was Amani wanting to protect her sister from the abuses that she suffered and witnessed. And we also see in the last paragraph that she um, the reminders of the abuse frequently get in the way. So that's again going back to unwanted memories, distressing memories. And then seeing men who remind her in some way of her abusers, her intrusive memories of the abuse start to kick in. And so that's the exposure to um, the trauma that is coming out and that is affecting. So emotional distress after exposure to traumatic reminders. And then we see that physiological reactivity. She's understandably avoiding and hiding. That's really to reduce the type of fight or flight reactivity that her body is having. She constantly feels unsettled and fears something bad is always about to happen. That's a startle response, constantly feeling unsettled and fearing something is about to happen. That's part of hypervigilance. So let's see. Here's another way of me breaking down all of the symptoms. For your final, I really want you to have a pretty complete understanding of this, especially as it relates to which symptoms go where. So I want you to know the different categories, so intrusive symptoms, avoidance symptoms, negative moods and cognitions, and arousal and reactivity. I'm not going to give you like super, super, super nuanced examples. They're going to be pretty clearly understandable when you see or when you're aware of an example, but just start to really get familiar with this slide. Okay, so defining hypervigilance. Hypervigilance to me, the more that I just like really learn about PTSD and learn about all of the symptoms, the actual definition of hypervigilance is that a person is very affectively reactive to trauma cues. But what we actually see is a different kind of behavior that is attached to hypervigilance. And this is really a person's responsive behavior that's oriented toward preventing future harm from occurring. So preventing future harm from themselves or preventing future harm for others. So Um, the case example that I put is after someone is mugged at gunpoint, they constantly look around whenever they are in a less populated area. That's really like the more overt textbook example of hypervigilance. But what we also see is that they tell people to never leave the house alone at night. They purchase pepper spray and then they take a self-defensive class. That is really hypervigilance. An example that I experienced was after my uncle and aunt were in a really bad car crash. One of their doctors, I think the doctor at the emergency room said, hey, you know, if you hadn't been driving this Audi, you probably would have died. I don't know if that's correct or not. But they were like, that Audi, because of Audi safety features, saved your lives. So my uncle, I remember telling the story about what had happened to us. I have a big Italian family. We're on a pretty big group chat. Sometimes it's great, sometimes it's a lot. But he was like texting all of us on the chat and then individually telling all of us that we need to buy Audis because they're going to save our lives. And he kept talking about it like, hey, really just know that like the Audi safety features, like he would like quote the safety ratings and compare them to other cars and would talk about how like he would go on these like really my uncle is a very for all intents and purposes, like a very highly functioning, emotionally intelligent, like pretty rational, stable guy. But he would go on these like long rants about how a lot of the cars that people drive are not safe, and that if you don't get a car that has appropriate safety features, it could be really catastrophic. So I was like, what is going on? And then I was like, oh my gosh, this is hypervigilance. He just was so hypervigilant about wanting to make sure that he was that we were all safe. It's ironic now because that's what car I drive right now. But when my husband and I decided that we were gonna get an Audi, I was like, okay, well, they do have good safety features, so I've been told. um, so that's hypervigilance. I could talk about hypervigilance a lot, but and I'll give you another clinical example of that in combination with negative moods and cognitions, especially as it relates to um, statements of responsibility and safety. It's just interesting how this shows up. And sometimes these symptoms are really high key, as we would say, and sometimes these symptoms are super low key. And this is where we could see this very subtly show up without actually knowing. Another example of hypervigilance is in the Royal Tenenbaums, where Ben Stiller's character, I'm always forgetting his character's name. I know his kids' names, Ari and Uzi, but his wife died in a fire, and so he would do these fire drills with his kids. That's hypervigilance. I've linked the video here. Pardon me, the actual video is like somebody recording the movie from a different screen, so the quality's not great, but it's a perfect demonstration of what PTSD can look like. The disconnect is that they're not saying, we miss mom, we're so sad about this. This has become a completely separate behavior and practice in this family's life, is wanting to prepare for future disasters. But the connection comes from what happened in the loss of his wife and of the kids' moms. So, okay, so on to another disorder, adjustment disorder. I'm going to take a break and take a breather. Trauma disorders are big disorders, and I know I'm really just giving you an overview. There's a lot more that you'll have to study, that you'll get to study, especially if you're working with individuals that have been traumatized. But I do hope that that provides you with an overarching understanding of this. And again, what we'll do in practice, what we'll do in class is practice continuously pointing out and better understanding the symptoms as we see them in subsequent vignettes. So adjustment disorder, we've talked about this a little bit, but what we know is that this can be a placeholder for other disorders depending on the timing, depending on the intensity and the severity of symptoms. And so just to reiterate, this is diagnosed when there's a development of behavioral emotional symptoms in response to some sort of identifiable stressor that have occurred within 3 months of the onset of that stressor. But what we know in most cases is that these symptoms have to abate by 6 months. And so um, so we have that time range of again, the stressors occur within 3 months of the actual issue, but then they go away within 6 months. And the other rule out is that the person does not actually meet criteria. There isn't a better disorder that we could identify, and there's not an exacerbation of a pre-existing mental disorder. So we're going to see that the distress is out of proportion to the severity intensity of the stressor, that they'll have difficulties, but are just much more pronounced, warranting an actual diagnosis. And we're going to see impairment with regard to other areas of their life. So again, they need a diagnosis, but it doesn't quite fit into other bigger, more fuller, longer lasting diagnoses. And so we can have, in criterion E, what it says is once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. I know that this is confusing in comparison to the presence of the persistent chronic specifier, but so we again know that by definition, symptoms can't persist for more than 6 months, but this is really when the disturbance is longer than 6 months and the response to that stressor has these enduring consequences. But again, we have to really demonstrate rigorous attempts, or yeah, we have to really actually demonstrate fully that we have tried to rule out this presentation against other disorders, and that the rule outs have not come up with any better disorder to fit into this person's experience. So we can have specifiers that are really catered to nuances of what's happening in terms of the person's behavioral and emotional reactivity. We can see that this is really coming out predominantly depressed, as far as depressed mood. We can see predominant anxiety and depressed mood, disturbance of conduct. So we just see this more so in behavioral externalization issues. We can see a mixed disturbance of emotions and conduct. So there's an internalization and an externalization. Again, does not fit into PTSD, for example, or it's unspecified. So in practice, if you work for the county, you might see this used a lot for a provisional diagnosis, that we don't have a clear history of what a person is coming in with. And so just as like a getting our foot in the door starting point, there's an unspecified adjustment disorder. It might actually come into crystallization that we diagnosed adjustment disorder with depressed mood, and that then that goes away. Or that's a placeholder for demonstrating due diligence to find out what the more accurate diagnosis is. I think in all of my clinical work, I've really only actually seen one adjustment disorder that comes to mind, like one case where I'm like, oh, this is actually adjustment disorder. And our contracts at the time, this is when I was working for the county, our contracts at the time were for 6 months. And so I remember, like, 5 months in, the person's symptoms, it was like a 14-year-old girl, her symptoms went away and she was back to like her very normal, pleasant self. And I thought it was pretty magical just to like actually see that happen. But she just needed the time to adjust to a big stressor in her life. I think her mom died. And it wasn't bereavement, it came out in other ways. And so this is where I go back to criterion D, that the symptoms do not represent normal bereavement, are not better explained by prolonged grief disorder. And that rule out is there because we have to see that the person has died 12 months, that their death, that the death has occurred after 12 months of us naming this disorder. I'll get to this in another slide. But there were, with my client that I was talking about, there were more complications, which is why it was adjustment disorder. But yeah, it was fascinating because it wasn't just sadness. It was like a lot of other types of internalized depression that I saw. Okay, so key difference between PTSD and adjustment disorder. What is it? Well, what this disorder, adjustment disorder, does not warrant is that it does not speak to the exposure of a life-threatening or safety-related situation. We do see that they have to have experienced some sort of stressor, but not at that heightened type of clinical example. And the other thing that we have to know is that PTSD is a much more complicated, concrete diagnosis. Like, there's just so many factors that go into the demonstration of PTSD that adjustment disorder isn't big enough. And the timing of the onset of PTSD versus adjustment disorder. So PTSD doesn't really have a window for when the symptoms have to end. That's really the biggest thing. And you can diagnose adjustment disorder if criterion A is not met in PTSD, but if the person otherwise demonstrates the similarities in PTSD, I feel like this is kind of confusing for you right now. So just know that when we do more thorough assessment, we know PTSD when we see it. And in the absence of that, that's where we can diagnose adjustment disorder as a provisional diagnosis. But the more we lean into it, the clearer that it is that they are not similar. Okay. Prolonged grief disorder, what I was stumbling over in the last slide was saying that the death had to have occurred at least 12 months ago, and that it had to be not just like a famous person, it had to be somebody that was actually close to the bereaving individual. The difference that we would see is that within children or adolescents, the death had to have occurred within 6 months ago. But since the death, there is a development of persistent grief response symptoms that are characterized by one or more that have been of these symptoms that have been present most of the days to a significant degree, and they've occurred nearly every day within the last month. So intense yearning and longing for the deceased person and preoccupation of thoughts or memories of the person that died. This is different than bereavement. In bereavement, we know that there's intense yearning and longing for the deceased person. Like my dad died in 2019 and I still think about him every day. I remember about 6 months into his death, to my bereavement, no, it was like 4 or 5 months. I think I said this um, in another lecture, but I just remember like feeling so hollow, empty, painful. But what I didn't experience, thankfully, was like this preoccupation of thoughts or memories of him. Like I wasn't like hyper fixated on them or just like really having flashbacks or memories of that. Um, and I was very relieved, for all intents and purposes, I was very relieved when at 6 months I started to feel better, just like what the DSM says. Um, Additionally, in prolonged grief disorder, since the death, so not even just within the last month, but since the death, at least 3 of these symptoms have been present for most days than not to a clinically significant degree, and that they've really specifically occurred nearly every day for the past month. So just to recap, as far as timeline, no, Jack, my cat is trying to walk on my keyboard. Um, mm-mm, that's what he did. Um, so we also see an identity disruption. So feeling like the person died with the deceased. There's a disbelief about the death. We very much see this in the Kubler-Ross model of denial, but again, usually there's a trajectory that does not continue into 12 months after. Jack, oh my goodness, this cat weighs 16 pounds and he is very persistent. Um, Avoidance of reminders that the person died, intense emotional pain, difficulty reintegrating into relationships, activities. Like, so this is an interesting demonstration of symptoms that are so similar to PTSD, but the content is different. And this is like the negative alterations in cognitions and mood symptoms, or kind of a combination of different criterion sets in PTSD. But again, the focus and the content is around missing the person so significantly. Emotional numbness, feeling as if life is meaningless, there's intense loneliness. Some of these reactions, like this is, we have reactions to grief that are akin to this, but we're going to see these in clustered behaviors that are really distressing and impair a person's life pretty significantly. And so what we have to identify is that the duration, the severity of this bereavement reaction, this clearly exceeds expectations for within the individual's culture and context. Um, I know we want to be aware of different cultures and how they grieve, and the way that they actually really intentionally saturate themselves in grief, which I think is so important for how that happens. But if we're talking about, so we have to take into consideration what's normal and what does a person's culture background give as far as permission, but then also how much distress does it cause a person in their lives. So we're going to rule out major depressive disorder. We're going to rule out PTSD. I go back to just with the overall conceptualization of grief and bereavement. I go back to page 184 in the DSM, and I think that I just love this component of this footnote of talking about distinguishing grief from major depressive episode, because there are predominant feelings of emptiness and loss, but within major depressive episodes, this is depressed mood and the inability to actually feel joy just in general. That's more overarching. Um, this can happen in bereavement, but really the biggest differences are missing the person and feeling as if life is meaningless because the person is not there, versus just feeling like life is meaningless. And and feeling the absence of joy. So the content, we have to see we have to see a focus on the content of what is actually causing these particular symptoms. So with depression, it's really internalized for the person. With prolonged grief disorder on the other end of this, um, at the bottom of 184, it says, if a bereaved individual thinks about death and dying, such thoughts are generally focused on the deceased and possibly joining the deceased. Whereas an individual that has made a major depressive episode, such thoughts are focused, such thoughts are focused on ending one's own life because of feeling worthlessness, undeserving of life, or unable to cope with the pain of depression. And so with PTSD, I'm going to loop this into the fold, we can see similar themes, but prolonged grief, these intrusive thoughts and memories are many aspects about the relationship, about the person, about memories of the person from the past. What we see in trauma is that there's usually like one specific memory that actually captures the nature of the exposure to the life-threatening situation itself. So this is a traumatic experience versus loss. So if you have any questions on that, please don't hesitate to ask. But remember the markers as far as rule outs too with regard to time. So PTSD does not have necessarily a cap for how long it has to last. And well, I guess prolonged grief disorder doesn't either, but we need to see that the death happened at least a year ago, and that the person is really preoccupied, that there's a disbelief about the death, avoidance of reminders that the person is dead versus avoidance of the reminders about how a person died. That's actually a good way to be able to distinguish the two, is that if somebody really close to me died and I had PTSD about it, what I would be experiencing is the negative aspects about the death itself. If it was a car accident, then I would be like, perseverating on the vision, the memory of the person being pulled out of the car, and I would be in disbelief about, not disbelief. This gets actually complicated when it's PTSD and grief at the same time. I don't want to dig myself into more of a hole, but just keeping it as light as I can. If I had prolonged grief disorder, then I would be continuously replaying memories of happy times with the person that died, and really avoiding any sort of pain because I had such intense emotional pain, because the person has died. Okay, dissociative identity disorder. This is such an interesting disorder. It's very controversial. Every time I talk about it in class, I see one person or hear of one, at least one person that just understandably does not believe in it. I have a patient that I've treated in my private practice, at least for a decade, but I treated them at the McDonald Center before that. And I know they have PTSD. They have many, many different personality states. There are some marked characters and people. They have like a mother superior type of a person who has an English accent, a British accent. This person is from the United States. And I know that the mother superior character has different handwriting too. I've seen it. They have a lot of kids or little ones that are part of their characterological profile within these different personality states. There are other females, there are other men. There are really subtle shifts when they become dysregulated and dissociate into these other personality states. But so the overall DSM definition is that we have to see a disruption of identity characterized by two or more distinct personality states. Often, what I know often is that there's a plethora. They're like really kind of like family trees or clusters. I did my best that I could, to make this visual for you all. This is not scientific. The problem with that, well, I'll get to that in a minute. We do know that a person has had to experience really, really significant trauma and really significant attachment issues. And that as a result of not being able to, the conceptualization is as a result of not being able to handle the pain caused by the trauma, the pain caused by the attachment issues, that they form different protective personality states. And there are personality states that are protective, that essentially when the person is offline in their dissociation, that these different states essentially fill in and operate for them. But then the children are really kind of a representation of the person's state and experience before the trauma actually happened. And so it's interesting. So my client that I meet with, I actually work with them in couples therapy. And it's not always been the case. I treated them at the McDonald Center, and then I treated them at the dual intensive outpatient program. And then after I left that program, I started working with my then patient, who is now a client, and her husband. And it's just been an interesting process because she is really a very functional person, but also is markedly impaired with her her DID. Um, so this is controversial because I don't think that people that when I treated my client at the McDonald Center, I would get into really significant, often loud arguments with our medical director about it, because she thought my client was faking, or she was my patient at the time. She thought the patient was faking. She thought it was borderline personality disorder. There's a really strong group of school of thought that thinks that this is borderline personality disorder because of how disorganized and dysregulated people with borderline personality disorder can get. I think that there can be comorbidity, but what I know is what I've seen when I've seen people that have borderline personality disorder get dysregulated. They get dysregulated, like they go offline, they might dissociate, but I've seen people in groups say that they have different characters where they say, I'm Gina now. It's like, no, it's not how that goes. This is my client that I've only worked with her, but she's ashamed, incredibly ashamed of the fact that she has DID. She really, I mean, in working with her for so long, I've had many conversations with her about being more open and expressive with her family about this, but in all of her shame, her guilt, just all of her defenses, she does not talk to her family about this. Her husband knows actually very little about her DID. He knows that she has it, but I've spent so much time with her. I know when she goes offline and when somebody else comes in, and it happens all the time. There are times that I'll be talking to her and then I have to stop and be like, oh my gosh, you weren't even present. Somebody else was present. So I have to be like, hey, so and so, did you hear what I said? And she's like, no, I didn't. Oh gosh. Okay, let me just repeat this. But somebody else will be having a full conversation with me. So she just switches gears really subtly, very quickly. Um, but people don't believe this. They think that this is like confabulation, that there's attention-seeking behavior around this. And the nature of this comes from a really significant, severe trauma. And it's just my perception, just after having seen all of these different nuances. I mean, sometimes my client goes underneath, I have a really big desk that's like a corner desk in my office, and my client will switch into one of the children altars and get overwhelmed. And often when these little ones, that's what we call them, when the little ones get overwhelmed, what they say is, I want to go home, I want to go home. And a couple times my client, the human person, will go underneath my desk and just get really scared and hide. And I have to say, hey, I have to use my client's name, come back, come back, come back, come back. Like I wait for realization and recognition to come across her face. Depending on what we're talking about, she goes really deep into her dissociation. And so I have to keep saying her name. Like I sometimes will go, like a whistle, hey, come back, clap, just try to like get her to like get distracted and come out of it. But a couple times she'll wake up and she looks around and she realizes that she's under a desk. I don't know how people can make that up. They're either fantastic actors that have some sort of secondary gain, or they are really actually impaired by the nature of DID. But because of the controversy around this, we unfortunately have limited studies or evidence of DID. Like, this is not something that a lot of people want to spend time and money researching. And so my generalized conceptualization that I put on the slide is really anecdotal based on what I've learned in working with my client's individual therapist, who is, her name is Karen Marshall. She is an incredible, competent, um, really significant subject matter expert on DID in the community in San Diego. She's an LCSW. I've worked with her for a long time because of the fact that we share this client. And so I've learned about different components of this, but what I've done is kind of broken this down to the waking self, so the human person that experienced the trauma. I see that we have children alters, so there are, again, for reasons that I explained, we have id alters, and but it's interesting. There's a range in that too. There are some, this is why internal family systems can be actually really helpful for treatment of DID, because it has a lot of similar conceptualizations to what happens within the person and their split selves. But there's like a firefighter type of subcategory of id alters, ranging from really pure emotional reactive alters to ones that engage in really maladaptive coping skills. And so my client has like 3 alters that are alcoholics. Not everybody's an alcoholic, thankfully, but like during COVID, when there were a lot of difficulties, my client once brought in a bottle of vodka um, to me at Sharp Mesa Vista. I guess I have not been working with her for 10 years in my private practice. It's been shorter. Um, Sorry for my timeline. I've worked with her for a long time in different modalities. Anyways, time goes by both quickly and very slowly, depending. But her drink of choice was always Jack Daniels. But she brought in a bottle of vodka that she found underneath her car seat. Nobody else in her family drinks. So I was like, "Do you remember this?" And she's like, "Nope. No idea how it got here, but somebody else bought it." And what's interesting is because somebody else has a penchant for vodka, where she would never drink that. And if you know anything about, I mean, I know we've talked about substance use disorder, that people have drugs of choice. Well, those that define themselves as alcoholics really have a particular type of alcohol of choice too. That's what they always go to. And so that's how I knew that there were distinct personality states. And that's another example of it. But she would find in the laundry, somebody was always hiding bottles. Before this, somebody would be hiding bottles of different types of alcohol. So it's interesting how this comes out. She also has an angry one, like it doesn't talk. It just gets really angry and snarls. Like I can see it when it starts to come out. It's when we get into conversations where my client has to take responsibility for their actions and reactions, and she doesn't always like doing that. And the angry one can get mad at me. And I'll say, okay, we call it the angry one. It's like, I see you. I know you're angry, but I really want to talk to my client because we've got to talk about this. So I know you're trying to protect her, but I'm going to ask you to leave and she's going to come back. I also see ego alters, so different alters that are like on the same page as her, that just have different, she has a couple different male alters, and when she was at the McDonald's Center, I'd see them come out, even just the fact that she wouldn't curl her hair. And she's very capable. She's really amazing. She's one of my favorite clients that I've ever treated. We have a very close relationship. We work together very well. I have a lot of appropriate affection toward her. But because I know her so well, I see just these different nuances. But one of the things, she does a lot of things really well, and she's very athletic. But what was interesting is I would see that she wasn't curling her hair, and there was like a week in treatment where all of the patients really wanted to play basketball. And that male alter was pretty present for the majority of the time, because they got to really be more themselves. And she was the only female that would play actively during the day with these young kids. I mean, she was like in her 50s at the time, would actively play basketball during the day with these patients. Um, and that wasn't my female client, that was one of her alters. She also has a super ego alter, so like alters like her mother superior, but these really like judgmental, over highly functioning alters that have a really strong agenda, which is kind of hypervigilance, to protect the person and others. So it's fascinating. Again, if we, whatever questions you have, let me know. But it is really rare that you're going to see somebody with DID. Please, please, whenever you, if you actually get to work with somebody that has DID, look me up, call me, let's talk about it, because it's going to be just one of the most interesting experiences that you have in treatment. So I never want to like try and, sensationalize this, but it's just a very fascinating clinical experience. And the key is not to react, not to like treat this person like a freak show, because that's exactly how they typically feel. This oftentimes goes very subtly because of the guilt and shame of that. My client misses out on a lot. Like, I don't think she remembered. She didn't get diagnosed with DID till she was in her 30s, because she was in treatment for her alcohol use disorder, and the clinical director knew that she had experienced a lot of really heinous trauma when she was a teenager, awful, unspeakable trauma. So the clinical director wanted to do EMDR with her, and just in general, the uh, DID is contraindicated with EMDR, because what happens is the person will just dissociate and will go into another personality state will come out. And so that's what happened. It's like, then the clinical director was doing EMDR and my client went offline, and then somebody else came out and just started talking to her. The clinical director was like, oh, this is different. this, this is not usually what we see. And that's what we learn in training for EMDR. So they like, oh, this is the contraindication. Now, like I said, with some schools of thought, identifying that DID is actually borderline personality disorder, we actually have to see a marked identity disruption that's different from the person's waking self. So the United States of Terror, although this is more of a dramatic demonstration of DID, they actually do a really good job. If anybody's seen the show, if you can watch the show, it's good. I think the first season is really fantastic. It kind of goes in different directions, and I think sometimes I don't know. Sometimes it's just it kind of takes away from the nature of what this person is experiencing, but I digress. They do a good job in really showing how this marked identity disruption comes out. And in the show, she stays in these alter type states for a lot longer than what I've seen for my client, at least. But she so Tara is the waking self. She's dissociated and her alters come out, she doesn't really coexist with them. Somebody else is present. That's what I see, and it's not often that my client is actually, when she's not in the driver's seat, it's not often that she's actually in the passenger seat seeing exactly what happens. Usually she's like in the trunk, if that makes sense. She's not conscious when she dissociates and when she goes offline and when another alter comes in. With borderline personality disorder, we still see that a person has the self, but they are really impaired by their fragile ego state. We'll talk about this a lot more in the personality disorders section, but it does not mean that people that have DID or borderline personality disorder um, don't share a comorbidity of trauma, because they usually do. Again, I'll talk about this more with borderline personality disorder, that trauma is not often the impetus, although it is present within the development of borderline personality disorder. But like I used Clementine in Eternal Sunshine of the Spotless Mind, which the group that's presenting will talk more about. but she is still present. She just changes her moods. Um, she doesn't shift out and become somebody completely different or even just like noticeably different. Her moods really dictate how she presents differently and how she changes her physical appearance. And so think about it like going back to this, like I'm going to split out of my waking self and then come into, I hope you, I don't know if you can see my cursor, come into one of these versus I'm going to become dysregulated. And then depending on how I need to protect myself or show up, I might switch gears as far as who I am and how I demonstrate myself. But that's, I don't know if that makes sense, but that's really what we see as far as the difference. So here are some additional resources on dissociative identity disorder, neuroimaging for those that have disorder, DID. I remember my client was telling me that she used to see her optometrist would see fluctuations in her vision. She would sometimes have like 20/20 vision, and then depending on who is in the chair, she'd have different vision. I don't know how accurate that is or not, but I just thought that was really fascinating. So we're almost coming to the close. Thank you for hanging on. Dissociative amnesia, this is an aspect of trauma. And this is the inability to recall important information, usually because of a traumatic, stressful experience. That's just different than forgetting. It's different than other neurocognitive issues. Um, and so this is what we would give if we don't have a bigger disorder to use. So like if a person's showing up and they just can't remember aspects of a period of time, then we can identify this as dissociative amnesia or localized amnesia, depending on what they're experiencing. So selective amnesia, we have retrograde amnesia, systematized amnesia, or retrospective memory impairment. So there's different clusters of how this actually shows up. Um, so a generalized dissociative amnesia is a complete loss of memory for most of the individual's life history. Like they just don't remember because they're offline. And sorry, zooming out, what we know is that the brain, in trying to process information of the trauma, will do one or both of these aspects where it will forget key important aspects of this traumatic event, um, or it will replay aspects of the traumatic event over and over again. When I do EMDR, what usually can happen is that a person forgets a lot about other aspects of what goes on in the traumatic situation, but they hyper focus on one thing. Like I remember I was doing EMDR for a person that had a single episode trauma, and um, they replayed this one situation over and over again where they saw their child struggling. That's like their child stopped breathing, and they only the only thing that they could remember of the event was like seeing their child blue. And then when we started doing EMDR, this is why I love EMDR so much. When we started doing EMDR, then we got to a point where my client was like, oh, now I can see myself. I saw myself doing all of the things that she had called 911 and they told her to start CPR. And she had this memory. She could see herself doing all of that. Before, she couldn't see herself doing that. So she had really like um, localized or forgotten about some of the aspects from that particular stressor. And then when we did it, a lot of the pieces came back together again. And because of the fact that she was able to connect with this really helpful, resourceful component of who she is, that really helped her to be able to process the trauma. But I just thought that was super fascinating. Um, Going back to the dissociative amnesia, all of this used to be under DID, and they parsed it out in the DSM-5 and the changes from DSM-4. But so what we know is that uh, there's a difference between forgetting key information about the trauma, about other aspects of a person's life during that time versus a dissociative fugue. So I think about my client that had DID. and she didn't remember a majority of being in college. Like she just does not remember. She doesn't remember the first time really that she was in treatment for her alcohol use disorder because her mother's superior figure. She doesn't remember actually giving birth to her kids. Like she doesn't remember like a lot of times. She just was offline. And her overall system perceived that she couldn't handle it. So other people came in and they started performing for her, for lack of a better way to say this. Um, Dissociative fugue is different. This is where a person wakes up and they don't remember who, well, where they, how they got there. So my client in my session, she'll do that sometimes. She'll be offline. I'll try to be bringing her back, or sometimes I will engage with the alters because there's a lot of information that the alters know that my client doesn't know that I'll ask about. And then I always seek to inform my client of what we talked about. But when she comes back to, she looks around in my office, and it doesn't happen that often. She looks around in my office like she's like, how did I get here? She looks at me, she looks at her husband, she looks at the clock, she looks at the office. I'm like, oh my gosh, you don't even remember driving here. So she's been offline for like a long time and then she shows up. That's a dissociative fugue. So that's where the bewilderment is really fascinating because she's bewildered as to how she got there. But that can be, so these can be components of DID that don't necessarily fit into that criteria yet, because again, what we have to see is that there are distinct personality states, then that can warrant the diagnosis of PTSD. But we can see symptoms of this that can actually be diagnosed separately. Okay, so derealization, depersonalization disorder, this is again the same concept, is that this can be present without the diagnosis of DID. These are trauma responses. This, this other slide, trauma responses, without it being crystallized into the distinct personality states. Depersonalization, derealization disorder, this is a lot more common. I would say, like when people check out, when they go offline, they might feel detached from their body, detached from the reality of the situation. They might feel like they're just an outside observer of their thoughts, their emotions. When people have explained trauma to me before and being in a traumatic situation, sometimes people say, I felt like I was floating up from my body. And I've heard this a couple times when people have talked about being sexually assaulted. I've floated up to my body and I was like at the top of the ceiling in a corner watching that thing happen to me. That's depersonalization. That is like a distortion, disconnect from their body, from their sense of self. It could be a disconnect from their experience of time, of absent being present, emotional or physical numbing, but depersonalization is the disconnect from their person, right? That's how you remember this. Derealization is experience of like being um, de- like floating around in like a dream. So I have this visual of Betty Draper after her dad died in the show Mad Men, and she was, I think she had gotten, I can't remember if she had received some sort of medication, but she was in these dreamlike states. She was like walking down this picturesque street and wandering around, is like totally in a dream. That was derealization. So detachment from surroundings. So person experiences this as like being unreal, like nothing around them is real. They're in this like dreamlike, foggy type of reality. I more often see anecdotes of depersonalization instead of derealization, but either can happen. So that detachment, disconnect from being grounded in the body, again, this can certainly be a trauma response or it can be a stress-related response. A more extreme type of stressor can cause this. So that's what you have for all the disorders. Treatment for trauma and dissociative disorders. There's a lot of different types of treatment for PTSD in general. I really love EMDR because, first of all, there's just a lot of research that goes to show how much more effective and efficient the treatment is. And what, this is not sorry, this is not a platform for me to like sell you on EMDR, but it's just really cool. So when after you have significant time in your experience as a clinician, and I really advocate for you to wait till after you get licensed, because you just have to, when you start doing EMDR, you really have to have like a pretty pronounced skill set, because a lot can happen in the session. A lot can happen just in terms of leading up to decision making of a person's appropriateness for EMDR, but a lot can happen in the session that you really have to like have a pretty strong competence to be able to navigate when something goes sideways. But I've seen people really click into place when we process their trauma. I've even done EMDR on myself and have, like, once I got in a I ran into a car when I was on a motorized scooter. First and only time I've ever driven a motorized scooter, but I ran into a car, and when I got home, I realized that I couldn't drive. And so I went to my office and I turned on my light bar and I reprocessed the memory, and I felt much better 30 minutes later. It was amazing. What EMDR uses is a theory called adaptive information processing, and it identifies that when we go through traumatic experiences, everything about the trauma gets locked into our neural memory network. So it gets locked into like a subcortical level of information. We really capture all elements of the trauma in terms of sights, sounds, feelings, thoughts that happen that are really hard to unhook. And so, like, compare that to CBT. Studies have shown that CBT is actually helpful in being able to change a person's negative thoughts about themselves as a result of the trauma, but it takes like 90, I think the metric is 96 sessions in comparison to 4 EMDR sessions. So it just really gets to a different level of it doesn't, it's not a matter of us thinking something through. And that's what prolonged exposure therapy, I think, can actually be really helpful, because what we want to do is not just have a person think through and undo their trauma. Cognitive processing therapy does a little bit of that. Um, and in my mind, people ruminate about things a lot. And if they could think about it from a rational perspective, they would. And so this is less about thinking and more about setting the brain up to actually reprocess the memory and restore it correctly. And that's what EMDR does. So again, if you have any questions about this, I'm happy to talk to you about it more. But here are the short-term goals that we would have. Like, we really want to give a person tools for coping, for distress tolerance, increase their safety and awareness of just the nature of their trauma or dissociative disorder. And then we would really want to work on like resolving the trauma, reducing avoidance behavior, really being able to like improve a person's overall functioning. DID is a lot more complicated in this sense. And again, because of the fact that it's not widely accepted, there's not a ton of evidence-based studies for this. And again, what I said, what we know about DID is that we really can't use EMDR with it. So this is where it's a much more challenging type of treatment to manage. But the crux, or the gist of treating DID, is that we really need to get everybody on board with changing their roles. And it's not to tell all of the alters to go away. It's like, hey, how can we all cohabitate with one another without getting in the way? How can we let this person live their lives and know that they are actually much more safe and capable of being able to do this than what you in your stuck state are allowing for? So yeah, okay, that's it. So here's the reading. That's my cat Jack that was trying to get on my keyboard. Um, so you do have a didactic for personality disorders. So next week we're going to talk about personality disorders. That's my favorite section. I have a really very thorough didactic for that. So I have a long but guided didactic if you want to do that, if you want to watch that. So there are clips that are actually posted on the Google Doc, but feel free to do that. Okay, thanks everybody. I hope you enjoyed this, and I look forward to talking to you more about this in class on Wednesday. Okay, thanks. Or I'm going to use this video for the future, or I will look forward to talking to you about this in class whenever we meet. Okay, thanks.